Good afternoon, and thanks for joining us for today's brand new Healthline 3 conversation. I'm Courtney Butts, your hostess, and joining us today is Dr. Michael Banda with Willis Knighton Bossier Surgical Associates. Thanks for joining us.
Thanks for having me.
Absolutely. So, Dr. Banda, you work in general surgery, and so you're, I guess you could say, a general surgeon, right? But tell me a little bit more about your specialty, what that means.
In general surgery, we cover a wide variety of illnesses, mainly the core of the abdomen, torso, things like gallbladder issues, appendix issues, hernias, colonic issues, things of that sort.
Okay, so a lot of different things.
Yes,
right?
and even small things like lumps and bumps on the extremity, we can remove those easily.
Okay, good deal. So, and you mentioned that you phrased it, like general surgery is anything but the heart, bones, and then what was the other?
Neurosurgery.
Oh, neurosurgery, yeah.
Yeah, I'll defer to my colleagues for those areas.
Okay, yeah, so tell me a little bit about your training. How long have you been practicing?
Well, I've been practicing for 27 years, all in Bossier City. My training was back at LSU Medical Center during the 90s under the late and great John C. McDonald. It was a very comprehensive general surgery residency training. We saw all kinds of general surgery and trauma. So with that, and I was fortunate enough to have a lot of great mentors at that time, and that's what I take with me, and I adhere to those techniques and principles from the mentors I was fortunate to be taught by in the years past.
Absolutely. So from the 90s when you started your training to now, I'm sure a lot has changed in your practice.
There's a lot of things have changed, but for the most part, we have emerging technologies, and of course a lot of additional supplies in the operating room that make our life as a general surgeon a lot more easier than those in the past. But yeah, things have changed, but for the most part, the core principles have remained the same.
Right.
Being attentive and focused on your patient, a proper exam, and precise operative technique.
Yeah, still practicing good medicine, right?
That's right.
Yeah, but like you said, those techniques, the technology has probably advanced. Or have you seen maybe your patients recover a lot faster with this new technology that you're using?
Well, not necessarily in a general standpoint, because what determines when a patient recovers quickly is it's really based on how soon they presented.
Okay.
For instance, in general surgery, we have what we call open techniques, which are essential at times, entering the entire abdominal cavity, laparoscopic techniques, and also robotic techniques. But regardless of the approach, what determines a patient's ultimate quick comeback and recovery really depends on the severity of the disease, any medical issues they might have, as we call comorbidities, certainly presentation. It's a patient who presents early in the disease process versus one who presents very late. Well, the person presenting very early is going to recover a lot faster and better, more likely.
Yeah, it makes sense. Okay, so typically with general surgery, you kind of are also dealing with abdominal pain, and kind of take me through those big things that we should be worried about if someone presents with abdominal pain. Does that automatically mean that they're going to have surgery, or when is it a problem?
Okay, and today we're going to be talking about adult surgery and medicine. In pediatrics, that's a whole different kind of a ball game there that I'll defer to my pediatric surgical colleagues for. In adult general surgery medicine, when we're talking about abdominal pain, things to look for are, we all experience routine run-of-the-mill, non-specific abdominal cramps, distension, discomfort, maybe some nausea, vomiting, maybe some loose stool or diarrhea. But when it gets past a certain point, and we've all been there, experiencing these little viruses or upset stomach because of some food we've eaten, But when it gets past a certain point, like after a day or so, and things start kind of localizing, centering over one part of the abdomen, to the point where, as one thinks about it, hey, I've never experienced something like this, and this is not feeling good, and it's getting worse. There may be associated fever, and so in that case, if it's within reason, if your physician can see you in the office in a timely fashion, like the same day, preferably, then by all means go and see your physician. But at times, one may not be able to see by a physician in the office, so you need to perhaps go to the emergency room, get checked out sooner.
Right, yeah, okay, definitely listen to your body, and if it's not going away, seek some medical attention for sure.
Exactly right.
Okay, well, if you're just joining us, we have those phone lines open. 318-219-4569 is the number to call if you do have a question for Dr. Banda. We are talking about abdominal pain and when maybe you should see a surgeon or when you should worry with that abdominal pain. So speaking a little bit more specific about this abdominal pain, what are those common types of treatments or common types of issues that you would treat?
Well, in general surgery, we see quite a bit of gallbladder issues, followed by appendix issues, followed by hernia issues, and issues involving the colon. Let's start with, for instance, gallbladder. You know, typically, and not always, not every patient goes by the textbook. Sometimes you really have to, as a physician, you have to really listen to the patient and kind of figure out what their baseline is, what their norm is. But typically in gallbladder disease, one might have an upset stomach after eating a meal. It could be a fatty meal, a spicy meal, followed by some nausea, maybe some pain up underneath the right rib cage that's persistent and severe. In that case, that's a good chance, but not always, but a good chance that it could be a gallbladder issue. And when we talk about gallbladder issues, one can have gallstones or one may not have gallstones. And so, for instance, if a patient gets to the point where he or she cannot stand this issue anymore, then come to the emergency room. And even though the emergency rooms are full and busy, by all means, just hang in there. And you know, some days are better than others, but that's a good place to get these acute tests ordered and accomplished soon in a timely fashion, so that if a patient presents with those symptoms like I mentioned, the emergency room physician might order a gallbladder ultrasound with some laboratory values. And depends on the laboratory values, what those show, and the results of the ultrasound. Sometimes the ultrasound will show stones, sometimes it won't. Sometimes it'll show maybe just an inflamed gallbladder with fluid around it. In that situation, and based on the patient's symptoms, if they have fever or if it's just debilitating, then
the pain being debilitating.
Yeah, and so to the point where they can't really move easily, then usually what will happen is the emergency room physician will consult us general surgeons, and we'll come see the patient in the emergency room. And at the very least, admit them for IV fluids, antibiotics. If they've been having nausea and vomiting for several days, then antibiotics and IV hydration with IV fluids would be initial start. And after review of their medical history and a proper examination, then perhaps surgery. And surgery consists of obviously removing the gallbladder. Now there's three modalities. One is the open approach, which is not so routine anymore. It was in the past. One is laparoscopic and one is robotic. Laparoscopic and robotic are essentially the same, small, minimally invasive surgery, small incisions, what have you.
Right.
And so I may, in my practice, I perform laparoscopic surgeries for sometimes 3 tiny incisions. And depending on the severity of the gallbladder disease, it could be 20, 25-minute operation. And
Gotcha.
so the gallbladder removed with that mean. And usually a day, the next day, depends on how the patient's feeling and recovering, and laboratory values may be rated for home the next day.
Wow, that's pretty quick
It is.
recovery period.
Now, other circumstances where the open approach is warranted, where just for instance, if a patient presented way late, maybe a week later than he should have come, then if it's not safe or we cannot see the structures laparoscopically, then we have to convert to what we call an open operation, where it's a lengthy incision up underneath the rib cage, right above where the gallbladder lives, and we remove the gallbladder with basically our hands and open techniques. Otherwise, it would not be safe to remove it otherwise. And of course, that would add to a extended stay as well.
Okay, yeah, so let's say, what would happen to that patient that waits a week or they never come in? What would happen if they waited too long to get that gallbladder removed?
Well, and the longer they wait, they're more at risk for having to have an open operation, which we will do is on the spot. We try not to, but necessary is necessary. And that patient will have a longer incision, and instead of going home the next day perhaps, or perhaps even later that evening, that patient may, with the open operation, be able to go home, 4 or 5 days later. Depends on, their issues, medical issues, and any complicating factors.
Yeah, so it could have been a simple procedure, but then it's, much more rough recovery period.
That's right.
Okay, well, we have our first caller. Sharita, thanks for joining us, and what's your question for Dr. Banda?
I don't have a question, but I would like to say that Dr. Banda has did several surgeries on me, and that his bedside manner is perfect. And if you want a good surgeon, he would be the surgeon to go to, Dr. Banda.
That's very kind. Thanks for Sharita for that compliment.
Well, I sure appreciate that. And, my number one goal is to take care of my patient. And that's all I see. And so it doesn't matter what time of day, what the circumstances are. I'm going to focus in on the needs of my patient, and it's more than laser focused on my part.
Yeah.
And so every patient can be assured of that. And if I can't come to the hospital and be laser focused on my patient that day, I'll just stay home.
Right, yeah, that's a good surgeon, right? I mean, I would want my surgeons to always be laser focused, right?
And that's the way I was taught and trained back in the 90s,
Yeah.
and that's a principle I will never give up.
That's awesome. Well, I think it speaks volumes to have, Sharita call in and say such a kind word for you. And if you're just joining us and you have maybe a question or compliment for Dr. Banda, just to give us a call, 318-219-4569. So we've talked about gallbladder. That's probably a pretty common procedure that you do in your
Yes.
practice. What are some other common ones, like appendicitis or hernias as well?
That's right. Next common thing we see, not necessarily in that order, but a common thing we see is appendicitis. And usually a patient may have some mid-abdominal pain. Kind of dull, and you really can't pinpoint anything. Maybe a little nausea, just not feeling well. And over the next several hours, that pain may shift down to the right lower abdomen. And usually that's pretty severe. And when that happens, again, it's best to get the advice of a physician. Definitely an emergency room again these are acute, and I don't propose everybody go to the emergency room for every little thing, but these are acute surgical issues
Right.
that are best handled very quickly in a timely fashion in an emergency room setting. And so a patient with right lower abdominal pain should come to the emergency room to get a workup, get lab work done, get evaluated by the emergency room physician. And perhaps one common test that's used is the CAT scan. And that will show us the state of the internal organs. And sometimes it's really not appendicitis. It could be a little what we call diverticulitis of the right colon, or just a colitis, inflammatory condition of the colon, which is non-surgical at that time. You can treat them with antibiotics, IV fluids after a few days. They're good to go home on oral antibiotics, and perhaps a follow-up later on with a GI physician to evaluate this further internally with a colonoscopy. Now, if it turns out being appendicitis, we can clearly see that most of the time on CAT scan. And again, this is laparoscopic on my part, 3 tiny incisions, and usually a 15-minute operation. And if this patient was operated on earlier in the day, that patient very well might be ready for going home later that afternoon or early in the evening, or if not, the next day. Now again, even though this is minimally invasive surgery, you can't compare apples and oranges. Everybody's going to respond differently. Everybody's physiological system is different. Some people recover quicker than others, and you can't change that no matter what. And so if I see a patient that, yes, we've operated on for appendicitis, 3 small tiny incisions earlier in the day, and on afternoon rounds, the patient is just still under the weather. This patient is staying overnight, IV fluids, continued antibiotics, and we'll reassess in the morning. And most likely, the patient will be feeling a lot better. Just took a little bit more time, and now this patient is appropriate for release in the home.
Okay, good deal. So I think this is a great time to talk about, March is Colorectal Cancer Awareness Month, and I know that you're not an oncologist, but you do probably see a lot of those, like if you said diverticulitis,
Yes.
right? That could be inflammation of like a polyp in your intestine. So, how important is it to address those issues like diverticulitis?
Very important because in the evaluation of abdominal pain, there's something in medicine called a differential diagnosis. And that is considering all possibilities that could be causing the pain. It could be inflammation of the stomach or a stomach ulcer. It could be a gallbladder, appendix. In this case, the colon. Sometimes, for whatever reason, a patient will have inflammation of the colon. We call that colitis. If it's just kind of diffuse and not very localized to one part of the colon, generally that's treated with antibiotics and IV fluids, and eventually that patient will recover, and then an outpatient colonoscopy to follow up on what may have caused this internally or inside the lumen of the colon. Now, that's a colitis that's just treated with antibiotics, non-surgical, but sometimes we have diverticulitis. Well, most of the time that's treated non-surgical. If it's just, as we call, a flare-up, and no evidence of rupture or abscess, infection, what have you, as we say, uncomplicated diverticulitis is really non-surgical. Now, the diverticulitis we operate on is when a patient has diverticulosis and actually ruptured. And you'll know it because that patient's in the emergency room and has severe abdominal pain everywhere. And as we call it, a washboard abdomen, where you barely touch them, they're stiff. And so that, combined with their history and their physical examination and a laboratory and radiology results like CAT scan, determines the need for surgery. And usually it's from the emergency room to the operating room. This is one of those open procedures where there's no time to waste. Midline incision, as we call it, exploratory laparotomy. We're not cutting any muscles in that. We're just going through what we call an avascular plane. It gives us full exposure to the abdomen, and we can remove the offending part of the colon, wash everything out, put drains in there. In those situations, sometimes we have to construct a temporary colostomy, which can be reversed later. And that's what gets the patient out of the dire trouble at the time.
Wow. So that's not a good situation you want to be in.
That's a very hard situation. You're talking a week or so in the hospital afterwards, where this may have been, prevented maybe if the patient presented a week earlier. So again, a take-home message is, if something doesn't seem right at home, the pain is beyond ordinary, please get looked at. Please come to the emergency room. it'll save the patient a lot of grief, and it's just a lot better recovery for the patient afterwards.
Right, and I just think of you could have maybe fixed it with, you said antibiotics and maybe IV fluids versus the procedure and having to take out part of your colon.
That's right.
Yeah, that sounds.
At least at that time. And the whole idea is just present early, don't be afraid, come and let's get this checked out. And I think we all can agree that, like anything in life, you know, we all agree that if we identify a small problem, let's nip it in the bud. Let's take care of it before it becomes a big problem. Same thing in surgery. Let's take care of it when it's small. It's the best thing for the patient, and a quicker recovery and back to their basics after that.
Absolutely, yes. So let's say someone has the just kind of staying with this topic for a second, diverticulitis. Is that kind of a recurring thing? Do people that have, maybe they've had it in the past, do they see it, pop up frequently?
In some patients, that is the case. There are some patients who may have 1 or 2 flares of diverticulitis, and they're great after that. They're treated with antibiotics, and it never happens again. Now, there are a subset of patients where they keep having flares, and that's one indication for elective surgery at the very least, where if a patient has multiple flares, I'm talking like 3 or 4 in a 6-month period, probably ought to consider elective colon surgery to remove that part of the colon, which is usually what we call the sigmoid colon, the left lower side of the colon. That will keep the patient from potentially rupturing later and having a catastrophic event.
Okay, and I like the way you're saying elective surgery. So you can elect to have some of these surgeries, like maybe removing the gallbladder or, other things that we've talked about, but you want to maybe not get to that point where it's acute and you
Right.
are in the emergency room. I mean, of course, you can't really predict when that's going to happen, but yeah.
That's exactly right. And we've been talking about the acute issues in general surgery, and because those are the ones that cause more devastating consequences for a patient. Now, there are a lot of patients we see in the clinic for elective surgeries, elective gallbladder surgeries, occasional elective appendix surgeries based on their circumstances, certainly elective colon surgeries, either for tumor or if a patient had recent multiple flares of diverticulitis and now the patient's better but does not want to go through that again, maybe with a preoperative bowel cleansing regimen, elective surgery, go in and remove that bad part of the colon, hook the 2 fresh ends back up together, and the plumbing like brand new.
Okay, I like it. I like it. Yeah, and never have hopefully any more issues after that. Okay, so we've covered a lot, but one thing we haven't really gone into detail on is hernias.
Right.
So tell me a little bit about those.
Well, we see in general surgery, we see a lot of hernias issues as well. Now, basically what a hernia is, it's an organ or tissue that's it's within the abdomen, and through a defect in the abdominal wall, an opening or what have you, that part of the tissue organ is poking out. Well, it's a dangerous situation to be poking out. And so, for instance, some patients have a natural defect around the belly button or up higher in the midline, or sometimes the patient's had multiple abdominal surgeries, and some of those incisions can break down and open up over time for various reasons. And so when we detect, say for instance, a lump underneath the skin on the abdominal wall, then either it's what we call a fatty tumor, but usually it's quite obvious if it's a hernia. And so depending on how it looks, if it's just straightforward, we may just recommend surgery on an elective setting, outpatient surgery, where they come in one morning. It may take 20, 30 minutes to fix this hernia, and then back home that same morning or later that morning. In some cases, if it's not too clear what we're dealing with, we'll get further imaging like a CAT scan to see, okay, well, there is an organ in there, but let's see how much of it and what else is involved. So we may have to investigate this a little further. So in hernias, it's as I tell my patients, hernias never go away. If they're a dangerous kind of hernia, like they have intestine within that hernia, then it ought to be fixed, because at some point it's going to become an emergency. And it's going to be a very hard recovery for a patient after something like that. So just like anything else, get attention early, get evaluated early, and let's see what we got, what's really going on, so that we can address the issue at that point in time.
What are those early symptoms of a hernia?
A lot of times what patients will see is a lump
Okay.
or a hard knot, either around the belly button or in the groin, an inguinal hernia, or somewhere along the length of an old surgery scar. And so you feel a lump or a hard knot, and at times it may seem to be poking out more, sometimes less. Sometimes you start having pain, irritation around that lump, especially when you're stooping over or lifting things. That's kind of a sign of a hernia right there.
Okay, good deal. Good to know. So we've got just a couple of minutes left, but you know, we mentioned earlier, we always want to know that when we go see our surgeon that they are, like you said, laser focused. But you know, you perform 3 surgery days a week. So how do you relax and unwind and, you know, get ready for your next surgery day?
Well, in general surgery, and I think all general surgeons out there listen to me right now, I think they'll agree that, man, we have some brutal days, brutal surgical days, in terms of the complexity of the surgical maneuvers we have to do. I mean, they could be very physically, mentally taxing. But routinely, you know, myself personally, you know, fortunately we have the Willis Knighton Wellness Center on the same campus, so
Cool.
that's convenient for me to go to on the way home. My wife is actively involved in her physical training. Aside from that, we'll travel when we can, and every chance I get, like this week, I'm driving down south to Hackberry, Louisiana, south of Lake Charles, where I have some great Cajun friends, famous Cajun family, the Burlesons.
Cool.
We go fish a lot. They cook like crazy Cajuns, and they know how to drop it like it's hot.
Oh yes, yes, and that's a great way to unwind. You got good food, great weather, you know, and probably some good music and great time spending time with people. I love
That's
that.
right. Yep.
Cool. So let's say someone is, you know, maybe interested in, I guess right now, if someone's at home and they're interested in surgery, it would probably be an elective surgery, unless if it's an acute or it's a you know, emergent thing, then you would probably direct them to the emergency room at this time.
That's
right?
exactly right. And again, I don't mean to flood the emergency room, but
Right.
I'm trying to take care of my patient's needs.
Yeah.
The acute, the severe feelings and pain need to be studied and examined quickly, like the same day, x-rays, CAT scans, ultrasounds, rather than on an elective basis 3, 4, or 5 days later or the following week. Let's get to it quick and let's deal with it, and it's the best thing for the patient.
Absolutely. Yeah. So if someone is at home, and what is the process like if they're wanting to schedule an elective surgery with you?
Basically, in my practice at Willis Knighton Bossier Health Center, we're on the website, and as we used to say, the phone book.
Yeah.
I haven't seen any phone book in a while.
Me
But in
either.
any event, call the office, and we'll get you scheduled in a very timely fashion. And certainly, again, that's for an issue that one patient might have. If it's more severe, again, the emergency room, and you'll still see me at some point after that.
Okay. And do you have that phone number that you
It's
could?
in Bossier City, 746-4460. It's my office number, and the hospital main switchboard. They can get you to the emergency room, 212-7000, Willis Knighton Bossier Health Center.
All right, good deal. Well, learned a lot today. Thank you, Dr. Banda, and thanks for joining us. If you maybe missed this and you wanted to rewatch this will be loaded on our website at ktbs.com/podcast. And again, you are located with Willis Knighton Bossier Surgical Associates, so you could also look up their website as well. Thanks, Dr. Banda.
Thanks for having me.